Start. This is nephron. Capsule, tubules, proximal, distal, arteries, efferent, and then veins. Our topic today, urinary or urogenital system disorder or pathophysiology of urogenital system. First of all, which first function is happening in nephron is filtration. Filtration happening here in capsule. To understand filtration disorder, we have to know that we have three pressures there, three types of pressure there. Which pressures? First pressure is the pressure of blood. This one is press the wall of the vessel. We call this pressure hydrostatic pressure. Understood? Then we have proteins. Proteins here also near the wall. These proteins create oncotic pressure. Oncotic pressure. O. But this pressure, it's working opposite filtration. Hydrostatic pressure press the wall, so it's positive for filtration. Oncotic pressure, it's prevent filtration, so minus. And last pressure is the pressure inside capsule. The pressure of primary urine. It press the wall of the capsule from inside. Also, it negative for filtration. Capsule pressure, C pressure, also minus. Again, please, three types of pressure for filtration. Hydrostatic pressure, it's positive for filtration. It means it lead to filtration. Oncotic pressure, negative. Pressure inside capsule, negative. So filtration pressure is equal hydrostatic pressure minus oncotic pressure plus pressure inside capsule. Understood? So hydrostatic pressure for filtration, oncotic capsule prevent filtration. Now it's very easy to understand. When filtration become more and when filtration become less. When hyperfiltration and when hypofiltration. Hyperfiltration when hydrostatic pressure high, oncotic pressure less, capsule pressure less. This is hyperfiltration. Understood? When hydrostatic pressure more. When. And first of all, hydrostatic pressure is depend on our general pressure. So when blood pressure high, so hydrostatic pressure also high. So urination more because of it. And it's visible among people with who suffering from hypertension. All the time, toilet, urination because hydrostatic pressure. Hydrostatic pressure more also, it could be due to what? Due to spasm of efferent arteriole here. It means outflow become less, something prevent. Then the hydrostatic pressure here become more. Understood? Then when oncotic pressure become less, oncotic pressure is protein. So when the protein low in our body, hypoproteinemia, then urination become more. Capsule pressure, this pressure inside capsule. I said it's caused by primary urine. When this pressure become less, when the urination more, it means the capsule continuously less from primary urine. It means in case of polyuria, understand? Polyuria leads to polyuria. Can you imagine? Polyuria leads to polyuria because polyuria leads to decreasing of pressure of capsule and it leads to increasing of filtration pressure. Means again urine. Can you imagine? Hyperfiltration also could be due to what? Hyperfiltration due to what? When the permeability of this membrane become high, of basal membrane of capsule high, in some inflammatory process. High permeability. Understood? This is about hyperfiltration. Then hypofiltration. When hypofiltration, in which cases the opposite. Hydrostatic pressure less, and it could be due to hypotension or dehydration. No water inside our body. Understood? Dehydration. Or this efferent arteriole become dilated. Then hydrostatic pressure become less. Or when the oncotic pressure high, it means when we have more protein. Hyperproteinemia. When, for example, when we give injection by protein contain solution. Understood? When when the capsule pressure high. When it could be high, when we have some obstruction here, for example, stone. Stone leads to what? To the congestion of primary urine here, because no urination. Then the capsule pressure become high. Then filtration pressure less. Note please, oliguria leads to oliguria due to obstruction. Understood? Obstruction. Do you remember the previous one? Polyuria leads to polyuria due to capsule also. Oliguria leads to oliguria also capsule. This is this is about filtration disorder. Hypofiltration also, when it could be developed. In case when we have nephrons countless. Nephrons count. How many nephrons in one kidney? Million or 1.5 million, yes? When they become less, also it will lead to what? Hypofiltration. This is about filtration disorder. Understood? Next, reabsorption disorder. Where reabsorption happening in our nephron? In tubules. We have proximal tubules and distal tubules. In proximal tubules, reabsorbed the organic products, organic materials. For example, sugar, amino acids, like this, organic materials. In distal, non-organic means calcium, phosphor, والآخره. Understood? Sodium. When reabsorption become suffered, what it can lead to? How do you think logically? What does reabsorption mean at all? When we take material substances from primary urine again to blood. So if reabsorption not happening, so these materials will be lost with urine. Understood? All reabsorption disorder or tubules problem, we call it tubulopathy. Understood? Tubules problem, we call it tubulopathy. Reabsorption disorder could be hereditary and occur. Can you imagine? Hereditary, yes, already delivered baby with tubulopathy, hereditary tubulopathy. Examples of hereditary tubulopathy: Fanconi syndrome. Fanconi syndrome. What is this syndrome? When the tubules cannot reabsorb 4 substances: glucose, bicarbonate, amino acid, and phosphate. So this baby will suffer from what? Hypoglycemia, because glucose not reabsorbed, so losing with urine. Bicarbonate, so he will suffer from acidosis. He lost what? Base. Then phosphate, he will suffer from bone problem. And amino acid, hypoproteinemia. Can you imagine this Fanconi syndrome? There is other syndrome of hereditary tubulopathy. This symptom is hereditary idiopathic phosphate diabetes. Phosphate diabetes. When the purely phosphate cannot reabsorb, and he lost with urine. So reabsorption disorder could be also occur. Not hereditary, not only hereditary, also acquire. It could be proximal and distal. When we have proximal tubulopathy, we will cannot be reabsorbed organic materials, as I said, glucose, amino acid, وهكذا. Distal, we will suffer from that non-organic materials cannot be reabsorbed. For example, calcium, phosphor, وهكذا, sodium, and they will be lost with urine. Tubulopathy could be also due to primary damage of tubules. This could be in case of nephritis, glomerulonephritis, pyelonephritis, وهكذا. Understood? This is about reabsorption disorder. Next our point, urine volume disorder. There are 3 pathologies: polyuria, oliguria, and anuria. Polyuria, normally daily urination, how much? About 1.5 liter. When the primary urine about 180 liters. Primary urine, but secondary, final urine, 1.5 liters. Can you imagine? Look, please, if it more than 1.5, it will be polyuria. The mechanisms of polyuria could be pre-renal and renal. Pre-renal and renal. Pre-renal. Yes, pre-renal could be physiologically and pathologically. Pre-renal could be physiologically and pathological. Physiological, when we just overtake water. Sure, it will be polyuria, yes? And could be pathological due to some diseases. For example, some system diseases or chronic disease. For example, diabetes. It manifested with polyuria, yes? Diabetes. Hypertension, as I said. Some endocrine disease, for example, vasopressin insufficiency. Diabetes insipidus, we call this. This is pre-renal. It means the problem not in kidney, the problem in the body. Understood? Renal polyuria, when the problem in kidney. Infiltration, as we said, hyperfiltration, or in reabsorption, as we said, tubulopathy. It will lead to polyuria. This pre-renal and renal polyuria. Next, if the urine less than 1.5 and more than 400 milliliter, we call this oliguria. Understood? Daily. Oliguria could be pre-renal, renal, and post-renal. Can you imagine? Pre-renal, the same. Systemic disease, organism disease. For example, dehydration. Understood? Renal, problem in kidney. Hypofiltration or increase of reabsorption. The opposite, increase of reabsorption. Post-renal, what it could be? Post-renal. Any obstruction or opathy, stones, for example. Stone in kidney, it will lead to polyuria or oliguria. Stone. Oliguria. No urination because stone, obstruction. Stone could be where? In cyst, urine cyst, or in urethra, وهكذا. Understood? This is about urine volume disorders. So polyuria, oliguria, last one, anuria. Anuria, when we have less than 4, it could be 50 or 100. It means that the kidney is already no work, out of order. In some cases of renal failure, last stage of renal failure, chronic renal failure, for example, or first stage of acute renal failure. Understood? This is about urine volume disorder. Next point. Urine contain. In urine, we know that urine must not have inside it sugar, proteins, yes, fat. So tell me please, if I find sugar in urine, is pathology or pathology? This pathology. Yes, we call it glycosuria. Glycosuria could be renal and non-renal. renal and non-renal. Non-renal, the famous example of non-renal is diabetes, hyperglycemia, and then glucosuria. And renal, problem in tubules. As I said, Fanconi syndrome, for example, yes, hereditary. Other contain problem, blood in the urine, hematuria. Hematuria also could be renal and extrarenal. Renal, extrarenal. Renal, due to some disease, for example, glomerulonephritis. Glomerulonephritis, when the filtration, including erythrocytes. We call this hematuria. Renal. Extrarenal hematuria, we can define it by the containing of fresh blood in the urine due to traumas, for example, fresh blood, understood? Or in rare cases of coagulopathy problem, coagulation problem, then it can lead to hematuria, blood bivalent, understood? So hematuria, renal, extrarenal. Next content of the urine is protein. Next urine contain protein. Protein. We call it proteinuria. Proteinuria also could be renal and extrarenal. But very rare in extrarenal. Protein in urine could be due to some damage of the same kidney, inflammatory processes, for example, pyelonephritis, and then protein become infiltrated and goes out by urine. This is also renal, but due to inflammation. And we have, in rare cases, we can find purely renal protein in urine. Renal protein. Due to damage of the tissue of kidney, this protein come out with urine, understood? So proteinuria could be extrarenal due to hyperproteinemia, and renal two types due to filtration problem or purely protein, kidney protein. And fat in urine, lipiduria. Next, inflammation and some inflammatory processes, very short. Glomerulonephritis, the most famous two types is glomerulonephritis and pyelonephritis. Glomerulonephritis, the problem in the capsule, inflammatory process in the capsule. But this is not purely inflammation. This is allergic inflammatory process. In some cases, due to tonsillitis. Yes, this is allergic reaction, third type of allergic reaction. Immune complex from tonsils and then goes to kidney and adheres here. And our immune system become attacked together with basal membrane. Glomerulonephritis is immune allergic or inflammatory allergic reaction, disease. It's manifested with hematuria because basal membrane permeability become big and then erythrocytes goes out with urine. Understood? Hematuria. About pyelonephritis, the pyelonephritis means it's purely microbial inflammation, the damage in the tubules, not in capsule, in the tubules. It's manifested usually with nephrotic syndrome. Yes, what is nephrotic syndrome? Nephrotic syndrome, when we have in urine protein and general edema, and in urine also we have lipids, fat, lipids, and hypertension. This is nephrotic syndrome. It's usually in pyelonephritis. And also there is other syndrome, we call it nephritic syndrome. Nephrotic and nephritic. Nephritic, you can add hematuria in nephritic syndrome. Understood? Yes, sir. In general, any patient has urinary syndrome of urinary syndrome. In general, we call it. What is urinary syndrome? When he has any symptom of kidney disease. Pain in urination, changed color of urine, anything. And then we call this urine syndrome. I hope you know which test we do for urine test, urine analysis. Yes, Nichoberenka test. This Nichoberenka test we have, and other test. One test for to know the content of urine, other test to know the volume of urine. And don't forget about something very important is the viscosity of urine. Yes, viscosity of urine. It must be also normally it's changing during the day. Why? Because we have meal difference. Something we have dry meal, something water, more watery. Then our viscosity of urine also changed. Is it good or bad? It's good. It shows that the kidney is working. Yes, it's doing urine more watery or less watery according to meal. When the viscosity of the urine become state, means continuously, it's bad. It shows that the kidney doesn't work. Understood? This the viscosity. Normally it's about 1000.15, 1000.18, the viscosity of urine. Yes, one like this. 15. Yes, absolute viscosity. Understood? This is about it. Finally, last point. I'm so sorry, yes, it's weather, but anyway. Renal failure. Renal failure. What does it mean? It means that the kidney become non-functioning. Renal failure could be acute and chronic. Acute is reversible. Chronic, non-reversible. Acute has, in general, 3 stages or 4 stages. Acute. Yes. First stage is latent stage. Then oligouria stage, because the urination becomes less. Then polyuria stage, compensatory stage, and then recovering stage. The kidney become health. 4 stages of acute. And the causes of acute renal failure and even the chronic renal failure, they have same causes: pre-renal, renal, and post-renal causes. Understood? Pre-renal, renal, and post-renal. But what is the difference? For acute renal failure, the causes are acute. For chronic, the cause is chronic. Understood? Repeat again. For acute renal failure, the causes, pre-renal, renal, and post-renal, they are acute. For example, what it could be: pre-renal acute cause. For example, shock, suddenly hypotension. Yes? So no urination, no pressure for filtration. Understood? This is acute. Or acute glomerulonephritis, renal. Or acute suddenly stone. Yes, suddenly, stone. It was small, then suddenly, stone. Understood? This is acute post-renal. Anyway, 4 stages. Chronic renal failure, this is bad, because the cause are chronic. He has chronic glomerulonephritis, chronic pyelonephritis, chronic amyloidosis, وهكذا. This disease, chronic disease, or chronic tuberculosis of kidney, or chronic renal artery problem, thrombosis of renal artery, pre-renal. The chronic has 3 stages. Chronic, 3. Latent stage, then the opposite, polyuria stage, and then oligonuria stage. The acute renal failure has 4 stages. Yes? Latent, oligouria, polyuria, recovering. Here the opposite, latent, polyuria, and anuria or oligonuria stage. The opposite. That's why chronic is bad, because it's finishing with what? Oligonuria. Oligonuria, no urination. So what will happen in our body? The urine will still in blood. This syndrome we call uremia. Uremia bad or very bad? Very bad, because urea is containing from ammonia. It's very toxicity. So for the forehead, for brain, toxic. It can lead to coma. For heart, also bad, because together with uremia, we could have hyperkalemia, potassium high level, because no sodium reabsorption. So potassium high level can lead to cardiac arrest. Can you imagine? For stomach, uremic gastritis. Urea also as inflammatory causing factor for inflammation. Uremic gastritis in women, uterus problem, vaginitis, uremic. Can you imagine? And also, while kidney cannot remove urine, so the water is still in our body. It will lead to what? Edema, hypertension. So what is the main indicators for hemodialysis? What is hemodialysis? Hemodialysis. Filtrate our blood by artificial kidney. Hemodialysis. What is the main indication for hemodialysis? What I said, brain edema, heart problem due to hyperkalemia, means hyperkalemia high, urea, ammonia very high in blood, uremic gastritis, these we call, lung edema also. These we call indication for hemodialysis. How much time he need hemodialysis, it depends on analysis, on blood and urine analysis. Some people has hemodialysis 1 day a week, once a week. Other 2 times a week. Other 3 times a week, like this. It depends at what? At the percentage damage of nephron. Yes, I forget to say this about the percentage damage in 3 stages chronic renal failure. First stage, 50% damaged. First stage of kidney nephrons, 50%. Second, about 70 damage. Third, 80-90% damage of nephron. It means how many nephrons are functioning? Just 10%. Can you imagine? This is very short about our today topic, urinary genital system pathophysiology. Thank you very much.